Thank you very much. I am pleased to present this. Thank you, Dr. Park, for allowing me to do so in the committee. I don't know if this gets higher. Perhaps I have to hold it in my hand. I think this is as high as it goes. Thank you for the opportunity. I'm very fortunate working at the Mayo Clinic in that I have some cardiologists there that are believers that pectus really does cause problems to the heart and cardiopulmonary system. And this is some work that they've put together, and unfortunately we're not able to come, so hopefully I will do them some justice in presenting. Sorry to... The patients, most of what I see are symptomatic. They come to me, majority of my practice is adults, and I see them, they're complaining of exertional dyspnea, of tachycardia, symptoms with exercise intolerance related to exercise. But if you do a more in-depth conversation with them, what you find out is that more than half of them will have symptoms that we describe as positional. So when they're leaning forward, when they're walking upstairs, when they're studying for long periods of time, leaning over books, when they garden, leaning down to get the plants or to tie their shoes, they become lightheaded and dizzy. And all of us that are surgeons can look at these CT scans and we see this right-sided heart compression that we know is an issue for, I'm sorry, I don't know how to make this thing advance. That we know is an issue for the patient. So we've looked previously at quite a number of echoes, and what we really know is that if you fix the compression, if you fix the pectus defect by placing bars, you will improve the right-sided cardiac output. In over 170 patients over 18 years, there was about a 30% gain. In patients that were an older subset at 30 years, we actually had a 65% increase in cardiac output. So you increase the size, you increase the flow through the heart. We've also seen more recently in a study that the strain of the heart improves with repair. And so strain is basically the efficiency of the contraction, the amount of blood that the heart is able to pass through. So knowing that, when we see a patient that comes to work and they talk to us about all these symptoms of how they're passing out and they're dizzy and they can't exercise, and you have their echocardiogram and it's read normal. Normal heart, normal size, normal valves, normal function. And you have this patient in front of you complaining of all these things, and it's very frustrating because your standard echocardiogram is done with the patient laying down. And when you're laying down, the gravity will augment the fill and your cardiac filling of the heart. So we wanted to look at, very simply, what's the difference between lying down and sitting up? And my Australian Shepherd volunteered for this slide to show you the difference. But he is laying down, and on the left, you can see the red arrow is your outflow track. And when you're laying down, it's wide open and the blood is flowing nicely. When you sit up, you have increased contraction, compression. In the pectus patient, not only do you have a drop down in the chest with the loss of the augmentation of the flow from gravity, but you have additional compression, especially in the very low, deep defects. And it does change. It changes that outflow. And so for this study, it was very simple. We looked at right ventricular outflow, RVOT, VTI. So that is a variable when you're running your echo Doppler. It's looking at the outflow track, and it's a signal. It's a flow ratio, and so you take a mean average of the area underneath that flow ratio. And so in adult patients, normal is from around 18 to 19. Women's a little bit lower at 17. And it's a very nice static finding, so it doesn't change variably. As you know, cardiac output is stroke volume times heart rate. So you take out the heart rate variable. So when you're looking at these patients, you're only looking at how much flow is going out through the right heart. So we looked at 29 patients that were symptomatic. We did a very simple test, had them lie down and had them sit up and look at their different outflow track indices. And we divided the cohort into less severe, moderately severe, and greatly severe, and then just looked at that. So a majority of patients were male, as would be expected. Median age was 28 years, and our Haller index was not extremely severe. Our median was 4.1, and so we had a nice range of not really big outliers. And interestingly, around 59% of these patients had positional symptoms that when we pulled their charts and analyzed were listed. Many of these, when you actually retrospectively, after fixing them, talked to them, didn't even realize the symptoms that they had because they've had pectus their whole life, and they said, I didn't realize that this wasn't normal, that when I bend over to tie my shoe, I feel dizzy. They thought that was normal. And so probably that number is a lot higher. And then otherwise, they had the pretty classic symptoms. So we looked at what is the change in flow out of the right ventricle. And so the Haller index did, when you sort it out, matter. So the Hallers that were between 3 and 4, they started off pretty normal. They had a fairly normal echo to begin with when they were lying flat. When they sat up, they lost about 19% of their cardiac output. And as you get progressively deeper into the Hallers greater than 5, you lost almost a quarter of your cardiac output, which is very symptomatic. And some of these patients actually, if you subdivide your extremes, some of them lost like 70% of their cardiac output, and they would literally almost black out when they lean over to try to do activities. And so in looking at positional echo, this is a very simple test. It doesn't add any cost to the exam. In the US, insurance coverage is becoming increasingly difficult. It's a fight every time with every patient, and a normal echo can often get a patient excluded from being considered as medically indicated. So for that reason now, we're doing this echo in all our patients, and this documented loss in cardiac output can actually make a difference in the insurance approval. You do see a significant decrease. You will see a small decrease in normal patients, but not to the statistical power that you do in these type patients. And this, of course, is just a small step study. The goal is to do exercise sitting, which I think Dr. Pilegard, your group, is already doing some work in, and to expand this, and so we can subjugate and look at the different aspects of, which patients does this really matter in, and is it Haller, is it location of compression, and otherwise. Thank you.